from Bastion, St. Kitts and Nevis, wherever you are, we're all dealing with a common issue, the issue of COVID-19. And we want to begin our discussions this evening by inviting opening comments from Dr. Martin, Dr. Arthur Winston Martin, PhD. A brief introduction. Dr. Martin is a research technology manager at Daikin in Alabama. He is a polymer scientist and chemical engineer who worked across several technology fields, including biotechnology. And he holds patents for 70 or more items in the U.S. and across the world. He's also, he has over 25 years of research experience. And lo and behold, he is a son of the soil. And he likes to call himself a humble son of the soil. Dr. Martin, good evening. And if you want to invite your opening comments.
Thank you, Mr. Backus, for that warm and welcoming invitation. So I'd like to say a pleasant good evening and welcome the listening audience in the Federation, the Caribbean, and wherever you are around the world. We are here this evening to talk about COVID-19 and the overall physical and economic impact it has had on the region. Our purpose is to inform, educate, and have a serious dialogue on responsibility and accountability. In our efforts to persuade and assuage individuals about becoming vaccinated, there remains a toss-up between social and moral responsibility and the passion for individual rights. Make no mistake, this panel is very sensitive to the pursuance of individual rights. However, we must also recognize that individual rights, social, moral, or ethical responsibility are not mutually exclusive. Let us have a frank, open discussion this evening about the right of the individual. I'm sensing from the many discussions I've had with individuals and postings on social media that there is a philosophically naive view of individual rights, not just in the region, but around the world. Your right is as good as the other person's right to exist. And your rights will begin to dissolve if what you do or don't do encroaches on the other person's ability to exist or survive. If one person infects an entire community and starts a community spread, then a civil society, private and public institution as well, must come to their defense for their own survivability. They then have the right to establish, whether it's a soft, indirect, or direct mandate rules or laws to protect life and property. This is the case with any communicable disease, and Dr. Raphael Kwanzaa would touch on that. COVID is indeed a communicable disease, a virus that is highly transmittable, chronic disease causing, and has significant death rate that can decimate your economy and deeply worsen your quality of life. I'm pleading for us not to succumb to disinformation on social media, conspiracy theories, fake videos, superstition, which vaccine should be of preference, political partisanship, past historical wounds, comments that are not fact-based, like our DNA will change. The government is tracking us. Vaccines were developed too quickly. I will wait and see. The capitalists will win and the poor man will lose. I've heard it all. What makes me nervous is the wholesale rejection of science and the dangerous misinformation that is on the rise. I think it is incumbent on all of us to be guided by the confluence of strong principles, hardcore facts, science, and medicine. And that is why we are here. People in the Federation and the region can crystallize the information and make the right judgment. After all, we in the Caribbean are smart and practical people, resourceful, resilient. We know how to deal with hardships for what we have faced as a people over 2 centuries. And therefore, we must overcome any encumbrances and be committed to protecting our families and fellow countrymen. Most of all, protect decades of enduring work you have put in to fortify your families. Please, don't give it away. With vaccine hesitation, the path to normalization will be tenuous at best. With a global death rate of 1.8% pre-vaccination, here's a scenario I'd like to propose to you. St. Kitts Nevis is based on a population of roughly 50,000, and a vaccination rate currently of 24.57%, more accurately 55.8% of the target population with a first dose, and 19.8% fully vaccinated, moving closer towards herd immunity, but still a ways to go. If we were to open the Federation with lax social distancing, ending quarantine as you know it, contact tracing, and end work from home, back to school full time, and begin business as usual, we are looking at a COVID infection rate of 10 to 15% of the unvaccinated population, and an estimated death toll of 200 to 400 people in 1 year. Can we really stomach this? Who do we want to trade? Or who do we want to roll the dice on? In my purview, such a death rate is unappreciable and avoidable. Furthermore, if contraction of the virus continues and complications develop, we should expect an overburdened and overwhelmed healthcare system. And Dr. Cuthbert Sebastian is here to attest to that. And finally, the erosion of the economy that was once stable or prosperous. This we cannot bear. In terms of the number of vaccines per 100 doses administered according to Reuters COVID-19 and Statistica across the region, here are some numbers. Dominica and Antigua leading the way with plus 40% vaccination rate and 30 respectively, followed by St. Kitts and Barbados, all in the plus 20s. Bahamas, Belize, Guyana, St. Lucia, they're way behind in the low teens. And Jamaica and Trinidad has yet to lift off the ground, less than 5% in terms of vaccination of the target population. These vaccination rates are not acceptable with respect to the death rate we have seen in some countries. For example, Jamaica, 47,396 infections and 862 deaths. Trinidad and Tobago, 16,549 infections and 294 deaths. Antigua, 1,251 infections and 42 deaths. Barbados, 3,968 infections and 46 deaths. St. Lucia, 4,818 infections and 75 deaths. Grenada is a much luckier, 161 infections and 1 death. And St. Kitts, 70 plus infections in which you had a recent outbreak and 0 deaths. According to a report in March by CNBC in 2021, St. Kitts are in the top 5 countries in the world with the lowest infection rate. Despite of the recent cases, I think the status remains unchanged. But why is this so? Because of the prudent policies of the current administration and the compliance of the St. Kitts Nevis people. The ISO standard COVID testing, which are pretty stringent, mask mandates, social distancing, and again, a stringent quarantining policy that many are aware of, who tourists as well as citizens and friends of the Federation who tries to visit. Frankly, they've been spared because of these measures. But these measures are transient, not long-term, and are therefore not sustainable. I would like to transition into giving a brief overview on the science of COVID-19 and vaccines. COVID-19, coronavirus, they are large, enveloped. You've heard this word so often, so I don't think it'll be over your head. It's a RNA, a positive stranded RNA. It holds genetic material, and it's a virus. It's responsible for infecting a wide variety of humans, some animals, and birds. These viruses contain sharp-like projections of what I'd like to call long-chain sugary proteins, and in a biochemical term, we'll say glycoproteins, which lies on their surface. They have crown-like shapes that you can see under a microscope. The viruses can replicate without the host, so they are classified as being parasitic. Viruses within the cell can multiply rapidly, they can self-replicate. That means an infection can start with just a small number of particles, and they're actually nanoparticles. That is the dose. We don't know yet the minimum infectious dose for COVID-19, but we might presume it is around 100 virus particles. When those dose reaches our respiratory tract, one or two cells will be infected and it will be reprogrammed to multiply and produce many new COVID viruses within 12 to 24 hours. It is a domino effect. The new virus will infect many more nearby cells, which can include cells of our immune system, possibly compromising it. And the whole process goes around again and again and again. With high viral loads, very rapidly the virus enters the cells of the lungs, heart, kidney, leading to chronic disease, and for those unlucky ones, eventual death. This is no joke. This is serious stuff. So let us talk about vaccines, right? They're the traditional protein vaccines. The measles, mumps, rubella, we all took them when we were kids, right? At that time in our lives, there were not a debate on individual rights. We lined up in school, the nurses came in and vaccinated us. So these type of traditional protein vaccines expose the body to proteins made by virus or bacteria and are made by using a weakened or inactive version of the virus or bacteria, typically grown in eggs or cells. It is expensive and takes years to develop. And then now here's the new technology using DNA and mRNA vaccines. They work slightly different in using part of the virus' own genes to stimulate our immune system. It is cheaper, shorter time span to develop, and has proven to be very efficacious and effective. Now, there are a list of them. There's the AstraZeneca, the Cuban vaccines, Soberana, there's the Johnson & Johnson, the Pfizer and Moderna, and Novavax. But the AstraZeneca is what is currently available and accessible to the Caribbean regions. 160.8 million confirmed cases of people with COVID-19 around the globe, and more than 3.3 million people have perished from the disease, according to the World Health Organization. In the US, COVID-19 was contracted by 32.6 million and with an estimated more than 500 deaths. This is the reality, my friends. COVID does not discriminate according to demographics, culture, political affiliation, or socioeconomic status. We are all vulnerable. However, I'll tell you this, it does discriminate for those who have comorbidities and those who don't take it seriously. Act now and consider the science and medicine. You are about to hear from the other panelists, and they would enhance by what they would deliver your ability to think about being truly free. A lot of work have been put into vaccine development around the world. Storage methods, shelf life understanding, delivery methods, efficacy and effectiveness. Do not abdicate your responsibility to keep your country safe and healthy. Vaccinate. Although I'm serving here as the opening batsman, as we would say in the lovely game of cricket, the medical experts will now take over and enlighten you on all the significant and pertinent information you need to know about COVID-19 and the impact it has on the region.
No,
so thank you, Clive.
Thank you very much. Thank you very much, Dr. Arthur Winston Martin, PhD, for opening the batting for this evening's innings. Our next presenter, because our methodology this evening is to have the presenters offer you a few words of advice, and then we're going to get more interactive a bit later on in the program. Our next presenter has experience on the front lines of this pandemic. His name is Dr. Richardson, Dr. Leonard A. Richardson, MD. He's a physician at the Johns Hopkins Health Systems Corporation, a faculty member and attending university physician, COVIDist, caring for hospitalized COVID patients. He's also the president CEO of Kingdom Medicine in Maryland, USA. And Dr. Richardson received his MD from the Howard University College of Medicine. He's been in medical practice for more than 20 years, and he's a proud son of the Federation of St. Kitts and Nevis. A very good evening, and over to you now, Dr. Richardson.
Hello, good evening. Thank you for having me. It is truly an honor to be here. Now, I'm going to talk a little bit about some of my experiences and what I've seen here in COVID. Of course, my colleague before me, Dr. Martin, who I've known for many years since we were in the same class, took all my time. So it's going to be very condensed and very small. So, but I practice medicine in Baltimore, Maryland. And one of the things that happened during this pandemic was a meeting of the minds. So they decided what was best practice. The leadership has a primer and they go through that, and they have to go through the preliminary think tanks, and the administration has to be set up. They have to decide what public health interventions need to be done, what testing and treatment, and so forth, and what emergency orders need to be done. So what we did here is the governor met with the Maryland Department of Health. The University of Maryland and Johns Hopkins University got together, traditional rivals, but now we had to work together. The National Guard got a field hospital from FEMA, and we set this up in short order. We had to, it was a very dynamic environment of shifting events, but that's what we had to do to make sure that this worked. Now, I had a little experience in the military because I'm a flight surgeon in the U.S. Air Force. So setting up hospitals in hostile environments is something that I was familiar with. So, but we jumped on board and we did what we had to do. What we didn't expect was the disinformation campaign that followed. We had to create culturally tailored, community-based interventions and messages so that we can reach people to let them know that a lot of this information was incorrect. So physicians who are usually hidden in the ivory towers and seeing patients and cloaked in the hospital, we had to now come out and we had to start talking to patients and talking to the public to let them know that this disease was real, and we had to start breaking up what all this disinformation was about. So, now everybody has access to a lot of information, but unfortunately, all the information that you hear is not necessarily true. So you have to make sure that it's evidence-based and listen to your leadership. Now, that's what we did here in Maryland. In St. Kitts, what I noticed is they did the exact same thing. You had the initial preliminary processes done. You had the COVID-19 Prevention and Control Act of 2020. The administration came about with the CMO, Dr. Hazel Laws. You had the medical chief of staff, Dr. Cameron Wilkinson. The National COVID-19 Task Force was set up, and you had NEMA. And they have done a phenomenal job. And I just want to emphasize that, just a phenomenal job getting to this point and managing this epidemic. So kudos to them. You also have to make sure that you thank really the folks who were instrumental, right down to the immigration folks, the police, everybody who, and the hospitality folks who are actually kept this thing at bay for almost 14 months. So that's what's important. So I just want to answer a few of the questions I've heard over the last 14 months. I've had a chance to be fully involved in this, be involved in the hospital, in the ICU, in the field hospital. I've seen a lot of death. I've seen a lot of success now coming on to the end of this pandemic, where people are now improving. And so I've seen the worst and now I'm seeing the best. So what your leadership is doing is trying to prevent you from getting to the worst part, because that's what we've seen. So I just want to emphasize that you need to follow the instructions that they're given, because a lot of research and anticipation went into planning the response to this. So in the hospital, you all are not at that point yet. You haven't had any deaths, but we've had many deaths here, almost 600,000. So, we have to treat these folks, and it's a very expensive proposition. So you don't want your systems overwhelmed. So you're talking about you need your oxygen. You see what's happening in India with just lack of oxygen. Things we use steroids and antivirals, convalescent plasma, and anticoagulants when people are hospitalized, but they're not at the point where they need the ICU. In the outpatient setting, even before they get to the ICU, if they have serious risk factors, we can sometimes give them the monoclonal antibodies, something like Regeneron, and we usually transfuse them if they're at high risk of developing severe disease. So that's one of the things that we do. We constantly encourage the N95 mask, gloves, gown, eye protection, and sometimes we wear the PAPR, which is that spacesuit looking thing, depending on where we are, because the concentration of the virus is instrument in how fast and how rapidly it travels. When you get to the ICU, that's incredibly serious. And this is a little technical. Most folks won't understand that, but you never know. Some doctors may be listening, but you want to make sure you're using buffered balanced crystalloids. You want to use norepinephrine as your first choice and avoid dopamine if somebody is in shock or blood pressure is falling. You want to make sure that an A-line is always present if you're giving presses, and low dose corticosteroids is important. And make sure you use a higher PEEP strategy. So I know that was Latin to some folks, but just in case somebody needed to get a little guidance, that's how we are aggressively treating those sick people. Now, when you don't survive and you die, I don't want you to forget the mortuary folks on the other side, and make sure that death certificates are filled out completely and thoroughly, because infection control is also important with these individuals, because we're losing a lot of our morticians simply because, you know, some of the death certificates were not coded properly and so forth. And even in the recovery phase, that you're not out of the woods yet. Right now, we have what's called the black fungus, which is mucormycosis, which is a fungus that people get after they've recovered from COVID, and that's spreading in India, and it's killing 50% of the people. So that's serious. And then long COVID. This is side effects of COVID infection, which is prolonged and that continues for a very long time. We're still discovering what that means. And let's talk about variants. Variants keep changing, and that is something we have to pay really close attention to. Right now, the vaccines are able to curb these variants, but we don't know for how long. Right now, there's a variant that came out in Vietnam, which is a blend of the Indian and the UK variant. And anybody who is at risk for whether they're immunocompromised, whether they're on steroids, or whether they're on chemotherapy, you're at risk for developing COVID. So yes, that question of can we get COVID a second time or a third time, the answer is yes. If you get a variant or if you're immunocompromised, you can get that. Another thing I wanted to mention, some people, I know they're saying, well, you know, what about the alternative therapies? What about marijuana? Is that even possible for us to use that? I hear it helps. Well, marijuana, we consider that a Schedule 1 drug, like heroin or LSD or ecstasy. And it has shown some benefits in treating the storm, the cytokine storm that people get. And it's usually young people who are healthy. And what that does is it curbs the cytokine storm. So that is one use that we see, and it decreases the inflammation in the cytokines. So yes, there are some benefits, but we also have to think about the depression, the dizziness that accompanies that, and also hallucinations, decreased blood pressure, increased heart rate, and judgment can sometimes be impaired. So we have to also consider that. Now, my colleagues talked about vaccines. I'm not going to get into the vaccines except to say that one of the questions I heard was, is this a real vaccine? Yes, it is. Vaccines come in various forms and various sizes. Some are inactivated viruses like flu and the polio. Some are weakened viruses like the smallpox and the MMR. Some are the subunit recombinant vaccines, toxoids, where they use the toxin from the actual germ, and your body then builds up an immunity to that. And of course, that goes all the way to adenoviruses, adenovirus-based vaccines, and the mRNA vaccine, which is the one that we're talking about, that folks are saying sometimes can change your DNA. Now, it's very important to know that the vaccine, sorry, it doesn't change your DNA. People are getting mixed up with a technique called CRISPR, a technology. And CRISPR is what scientists use to change the genetic blueprint in plants and animals and even human beings. So this is what a technique where they go in and they splice out some DNA and they replace it, and it can be used for GMO foods where they can make tomatoes stay red and not go brown. They can use it for mosquitoes, so they can create malaria-free mosquitoes so that they can get rid of the mosquitoes that have malaria. And just recently in humans, they just used a medication called Zolgensma to treat a baby for spinal muscular atrophy. So it went in and clipped out the abnormal DNA, put in normal DNA, and basically cured something that was fatal. So just wanted to mention that folks get that mixed up sometimes. The CRISPR technique is what we'll use. We've had some success with sickle cell disease, but it's not the same thing as the mRNA vaccine, which is not integrated into the body's DNA at all. It's broken down once it delivers its message to tell the body how to produce an immunity. So that's important. Just wanted to mention that. Another question I got, can pregnant women take the vaccine? During trials, pregnant women did get the vaccine, and we didn't really have a whole lot of negative effects from that. Pfizer is actually we can actually give Pfizer to pregnant women now because we've shown that the woman can pass the antibodies on to the baby if they get the vaccine. And also, if she is nursing, she can also pass antibodies on to the baby, and that's from the vaccine. So that's something that we definitely, you'll still want to discuss that with your doctor because there may be some contraindications for you as a pregnant woman. And some research has shown that there's a slightly increased risk of a premature birth. So we want to make sure that we do that. Another question. Can we be vaccinated after we've had COVID-19? And the answer is yes, we strongly recommend that. So some people say, okay, I've gotten the vaccine, so I've gotten the infection, so I don't need the vaccine anymore. The answer is, yeah, you still do, because you get a more robust response from the vaccine rather than from the natural infection. And it's a more measured thing. So once you recover from the vaccine, we're now recommending that you get the vaccine unless you've had a treatment of convalescent plasma or immunoglobulin therapy. So I'll stop there. I think my time is up, and I'll answer questions at the end if necessary.
Well, thank you very much, Dr. Leonard Richardson. Very informative presentation. We're going to move right along. We've got our panelists here, a very distinguished panel, and we want to go now to Dr. Colette Lee Lewis, who will discuss the influence of COVID-19 on renal disease. And of course, we want to give her an opportunity to explain to us how that really works. We know that in the Caribbean in particular, when we look at hypertension and diabetes, either most people have it or we know someone who has it. And Dr. Lewis, I'm told, is an 18-year veteran in nephrology. 18 years experience may be a better term rather than saying veteran. I hope you don't hold that against me, please. That one I'm just having some fun. And she's been actively serving patients in Georgia, USA for the last 16 years. And she's a graduate of Drexel University School of Medicine in Philadelphia. A very good evening to you, Dr. Lewis, and it's your mic.
Thank you. Good evening, everyone. Thank you, Mr. Backus. As Mr. Backus has said, I'm a practicing nephrologist in Georgia, and I take care of patients daily, in local hospitals and on an outpatient basis who have longstanding kidney disease and those who develop short-term injury to the kidneys. So during this pandemic, I've had the opportunity to take care of quite a few patients who have developed COVID-19, those who have required ICU care, um, the sickest of the sick, and those who have not been as sick, but yet have had issues with their kidney. So COVID-19, as we know, is caused by the SARS-CoV-2 coronavirus. It's a virus that causes respiratory illness in humans because it is predominantly airborne. But in addition to lung disease, other organs in the body are affected, including the kidneys. Other organs and systems include the liver, heart, the gastrointestinal, the hematological, which is the bone marrow and blood, and nervous systems. And these, and of course, infections thus cause a high rate of death or mortality and sometimes causes multi-organ failure in these infected patients. The kidneys are two bean-shaped organs, each about the size of a fist, that are located below the rib cage on either side of the spine. And we know that healthy kidneys filter about a half cup of blood every minute, removing waste and extra water to make urine. What are some of the other jobs that the kidney does? We know definitely removes waste and extra fluids. We know it also helps to control blood pressure. But we know also that kidneys need adequate levels of blood pressure to work properly. And such, in patients who are extremely sick, where their blood pressures are very low, in sepsis, they are prone to kidney injury. Other things that the kidney does, it helps to make red blood cells. It makes a hormone called erythropoietin, which stimulates your bone marrow to make red blood cells and prevents anemia. It also helps to keep the bones healthy and also controls the acid levels in the blood by getting rid of excess acid. As spoken before by Dr. Richardson, some of the comorbidities and conditions that have been associated with severe illness and mortality include cardiovascular disease, which includes high blood pressure, diabetes, COPD, which is chronic obstructive pulmonary disease and other lung diseases, cancers, chronic kidney disease, which I will speak about, obesity, smoking, to name a few. The most common causes we know of chronic kidney disease worldwide are diabetes and high blood pressure. Hypertension is an important risk factor for cardiovascular disease in the Caribbean and globally. It is responsible for approximately 51% of deaths due to stroke and 45% of the deaths due to ischemic heart disease, which are the leading causes of death in the Caribbean. The prevalence of high blood pressure is high, affecting approximately 35 to 38% in St. Kitts, BVI, and Grenada, 21% of all adults in Barbados and Trinidad and Tobago, and about 25% of the population in Jamaica, according to stats from the World Health Organization. So we know that high blood pressure has far-reaching consequences, and thus lowering blood pressure helps with lowering the cardiovascular disease, and thus stroke, coronary artery disease, heart attacks, diabetes complications, and chronic kidney disease and early death. In the Caribbean, the overall prevalence of diabetes mellitus, or blood sugar, or sugar as we say, is estimated to be approximately 9% and is responsible for 13.8% of all deaths among adults in the region. Diabetes is therefore one of the major public health challenges for the Caribbean in the 21st century. And this comes from the International Journey of Equity Health, which was published in 2015, these stats. The Federation of St. Kitts and Nevis has approximately 13% prevalence of diabetes per International Diabetes Federation, Diabetes Atlas in 2019. Thus, there would be an increased incidence of the risk factors for chronic kidney disease. Chronic kidney disease, or CKD for short, is defined by the presence of kidney damage or decreased kidney function for 3 or more months, irrespective of the cause, whether it be high blood pressure, diabetes, or other diseases. This persistence of the damage or decreased function for at least 3 months is necessary to distinguish chronic kidney disease from acute kidney disease or acute kidney injury. Kidney damage refers to the structural abnormalities whether established by a kidney biopsy or by imaging studies or from markers which we look at from urinary sediment, such as increased protein excretion into the urine. This decreased kidney function refers to a decreased ability of the kidney to filter these wastes and poisons from the blood, which is usually estimated by something we calculate as the glomerular filtration rate, or GFR. And this is used, what we use to calculate this GFR is the serum creatinine, which is a waste product of muscle, which is only excreted by the kidney. So kidney failure is the end stage of chronic kidney disease and is defined as severely reduced kidney function, requiring treatment with dialysis. The term end-stage kidney disease generally refers to chronic kidney failure treated either with dialysis or transplantation. Acute kidney injury may therefore complicate chronic kidney disease and hasten its progression, producing kidney failure or shutdown. So setting the background and definitions of what is considered chronic kidney disease, let's define what is acute kidney injury. And this is what we see a lot of in COVID-19. Acute kidney injury, therefore, is an abrupt, quick onset, usually reversible decline in the GFR or kidney function. It results in the elevation of serum blood urea nitrogen, so these are the wastes, the creatinine, and other metabolic waste products in the blood that are normally gotten rid of or excreted by the kidney. So an infection with COVID-19 definitely can damage the kidneys and increase the risk of needing kidney dialysis. Lessons learned in the United States and other countries that have been ravaged by the pandemic show that there has been a rise in chronic kidney disease cases. That is permanent damage to the kidney, though not total failure of the kidney because of this infection. Patients with kidney disease also have other illnesses or comorbidities, including high blood pressure, diabetes, heart disease, that are risk factors for poor outcomes with COVID-19 infection. Apart from lung disease, acute kidney injury is one of the most frequent and most severe organ complications in this infection. The virus has been detected in kidney tissue, and this is one of the things that we believe causes such damage to the kidney. So patients with chronic kidney disease before and on dialysis, and specifically transplant patients, kidney transplant patients, they are an especially vulnerable population. The increasing number of COVID-19 infected patients with kidney involvement led to an evolving interest in why there was so much acute kidney injury. So COVID-19 kidney damage. So we know that some people show signs of kidney damage, even those who have had no underlying kidney problems before they were infected with COVID. And that was one of the key things that was seen in China and especially in New York when the pandemic began, that people had moderate to severe kidney injury. Signs of kidney problems in patients with COVID-19 include high levels of protein in the urine and abnormal blood work, abnormal waste products in the blood, abnormal electrolytes, sodium, potassium, increased acid levels in the blood. The kidney damage was in some cases severe enough to require dialysis, and during the pandemic, hospitals which experienced surges of patients who were very ill with COVID-19 reported not only running short on ventilators to support breathing, but also the machines and sterile fluids needed to perform kidney procedures like dialysis. In some cases, treatment had to be rationed as supplies were scarce. Many patients with severe COVID-19 are those with coexisting chronic conditions, as previously said, high blood pressure and diabetes, both of which increase the risk of kidney disease. More alarming was seeing kidney damage in people who did not have kidney problems before they got infected with the virus. So questions arose as to how does COVID-19 damage the kidneys? We feel that COVID targets the kidney cells. The virus itself infects the cells of the kidney. The kidney cells have certain receptors that enable the COVID virus to attach to them, invade the tissues, and make copies of itself, potentially damaging the kidney tissue. Similar receptors are found on the cells of the lung and the heart, where the new coronavirus has been shown to cause injury. Another way is that too little oxygen can cause kidneys to malfunction. And with the pneumonia that the COVID causes and the severe decrease in oxygen in the blood, that in itself causes additional damage to the kidney. As previously spoken by Dr. Richardson, the cytokine storms can also destroy the kidney tissue. The body's reaction to the infection may be responsible as well. The immune response to the new coronavirus can be extreme in some people, leading to this cytokine storm. When that happens, the immune system sends a rush of these cytokines into the body, which are small proteins that help the cells communicate to fight an infection. But the sudden large influx can cause severe inflammation, killing and destroying healthy kidney tissue. The other thing that we've found is that it also causes blood clots that might clog up the kidneys. We know that each kidney has about 1 million nephrons or filtering units. And the kidneys are like filters that screen out these toxins. And when the clots form in the filtering units, it affects the function of the kidney and its ability to filter the blood. So long-term implications of this acute kidney injury. It was discovered that recovered COVID-19 patients who had acute kidney injury or the acute renal failure should be seen regularly by kidney doctors after their infection, or followed by their primary care physician to follow their kidney tests, because their risk of developing permanent kidney damage is higher than others. So when we talk about acute kidney injury, what are some of those things that we look for as physicians, especially when we talk to family members, is we talk about decreased urine output. We talk about fluid retention. These patients tend to hold on to a lot of fluid. They get swelling in the legs, the ankles, the feet. And because of extra fluid retention, they get shortness of breath, which also exacerbates the pneumonia that they have and those issues. Other signs now of chronic kidney disease. So maybe after they have developed, they got COVID infection, they got some damage to the kidneys, they also had permanent damage, some lasting damage, and developed chronic kidney disease. So some of those signs of chronic kidney disease include more fatigue, less energy, having trouble concentrating, having trouble sleeping, dry, itchy skin, the need to urinate more often, especially at night, sometimes blood in the urine, foamy urine because of excess protein excretion in the urine, because the filters of the kidneys have been damaged, increased puffiness around the eyes, swelling around the eyes, which we call periorbital edema, swollen feet and ankles, poor appetite because of increased waste products building up in the blood, and cramping muscles because of abnormal electrolytes. During this pandemic, I have treated quite a few patients who developed acute kidney injury during their course with COVID-19 infection. Those who recovered from COVID-19, some have had lingering damage to the kidneys, and many of them, their kidney function definitely has not resumed to its previous baseline. Many of the ill patients, once developing kidney failure, have gone on, of course, to pass. And unfortunately, this is a real problem with this pandemic. Of one note, I have one patient. He had some mild kidney damage prior to the pandemic, and I followed him for several years, and his kidney function was stable. He developed COVID-19 infection. He was not the worst he was not in the worst shape, but he had COVID pneumonia. He developed acute kidney injury, required dialysis, and is now dialysis dependent 1 year post-COVID infection. During this process, because of being sick and taking a long time to recover, it affected his family because he was out of work, and the economic impact to his family was pretty severe. He has now returned to work, but of course is stuck on dialysis. He's currently being evaluated for transplant. So, of course, this is a very serious matter to have COVID infection because it can affect the kidneys long term. And of course, the impact of chronic kidney disease is very high. I would suggest to all that if you have the ability to get the vaccine, that you take it, because COVID-19 infection respects no one. It respects neither socioeconomic status, it respects neither class, it respects no one. And the severity of illness that you can experience is pretty bad. And of course, as we know, many people have died from this. And of course, there are long-lasting effects. And as a kidney doctor, I implore you, kidney disease is nothing to play with. So I would ask that you would take the vaccine if it's offered. Thank you.
Well, thank you very much for your presentation, Dr. Colette Lee Lewis. And I do have to do a bit of housekeeping here. I did mention in the introduction of Dr. Arthur Winston Martin and of Dr. Leonard A. Richardson that they were sons of the soil. And I went ahead and introduced you and didn't say where you're from. So I do apologize for that, and I want to set the record straight and let you know that Dr. Lee Lewis is from the Emerald Isle. She's from Montserrat, and thank you very much for that bit of housekeeping. Moving right along now with our discussions this evening, let's talk a little bit now about children and adolescents. Our next presenter is Dr. Julian Wint Martin, DNP. Dr. Wint Martin is a pediatric nurse practitioner, DNP at the Huntsville Hospital Women and Children's Hospital in Huntsville, Alabama. She's also been in the field for over 15 years and has over 20 years experience as in pediatric nursing. And she received a doctorate in nursing from the University of South Alabama. And I'm told that issues in the Caribbean are very close to Dr. Wint Martin's heart. She was born in the land of wood and water. She was born in Jamaica, and good evening to you. I think your mic may be muted. Is it?
Yes,
Yes.
I just good evening, everyone.
Good evening.
Today I'd like to discuss the effects COVID-19 has on the pediatric population. The CDC reported that 6,800 children have died from COVID-19. And this is about 0.3% of the reported cases based on 2.3 million that has been reported in 78 countries. So with that number, it's not a significantly high number, but it is a notable number. The infection rate among the pediatric population is about 14%, which personally I think is higher because most pediatric patients are asymptomatic or just have mild symptoms, such as runny nose, cough, or congestion, which is often overlooked and thought of as a common allergy or a common cold. And so I definitely think that that number is significantly higher. The question now becomes, since there are mild cases with the pediatric population, or some are even asymptomatic, why is it important to vaccinate children? And that's a valid question that I hear all the time. There are several reasons. One is that children are super spreaders. So especially in the Caribbean, when we live in multi-generational household, we are around our grandmother, our aunts, our uncles who has comorbidities such as diabetes, hypertension, obesity. These children that are probably in school or are playing with friends and has what everyone thinks is a cold could very much have COVID-19. and bring it home to a family that's vulnerable. It may not have a severe effect on the child, but to the vulnerable population, it could result in several, like Dr. Lewis just said, renal failure, death, and other severe illnesses. My family, my daughter was diagnosed with COVID-19 during the pandemic, and her symptoms were mild symptoms. She basically had a runny nose and headache, but we quickly identified that as possible sign of COVID. So we had her tested and she was positive. We were able to quickly isolate her. For 10 days, she was in quarantine in her bedroom, and we were able to prevent infection to the rest of the family. That was important because both my husband and my daughter has asthma. And of course, with those chronic illnesses, it could have had dire effect on them. So the fact that children are super spreaders, that's a major reason why children needs to be vaccinated. The most daunting reason, however, is a complication that we're seeing called MISC. And MISC is an acronym for a multi-symptom inflammatory syndrome in children. The pathophysiology of MISC is not fully understood. A lot of research is still needed in that area, which is why it's even more important that we are aware that that exists. The complication usually starts after the acute phase. So the acute phase of COVID is usually the acute phase ends after about 3 weeks. At that point, the clinical presentation are usually fever. Fever usually is for about 3 to 5 days. There's gastrointestinal symptoms such as abdominal pain, vomiting, diarrhea, and the children often present with a red rash that covers the face and the trunk and the arms, and also conjunctivitis, which is what we call pink eye. Not every child has all the symptoms. Some may have maybe 2 of those symptoms. And however, in the emergency room, which I work, most of these children present in shock. So their blood pressure and their heart rate, the blood pressure drops, the heart rate becomes elevated. And so it requires blood work to confirm that they have antibodies against COVID. One of the things that's amazing about this is that 90% of the kids that I see, this is not statistic proven, it's just based on my experience. Most of the kids that has MISC, their parents will report that they weren't aware that they had COVID-19. So they were asymptomatic children who no one knew that they had COVID-19. But when we do the antibodies, they come up positive for the antibodies. And most of these children require ICU care. They have to stay in the ICU until they're stabilized. The average age for these cases, or it's say between 6 and 12 years old. And for some reason, Blacks and Hispanic are disproportionately more affected. So it is important that early recognition of MISC is done in the clinical setting, and this will, prevent a better outcome. The other reason why kids are affected by COVID-19 is the psychological effect that it has on them. I've read a lot of research on the psychological effect, and I'm going to mention 2. One was done in China. We haven't had a lot, I guess China is where the COVID-19 started. So there's a lot of research that's done on the impact that it's had on children. A research that was done in the end of 2020, the participants were children aged 7 to 18, and it was a large study. It had about 8,000 participants. They checked for different psychological illnesses, such as depression and anxiety. And the research showed that 43% of those children had clinical signs of depression, with 37% having anxiety. Another study was done in Italy and Spain. Once again, it was done in areas where COVID had hit first. And this one included the parents were the participants. So it was a large study also, had 1,143 parents. And these were parents who had children between the ages of 3 and 18. 85% of the parents reported that their children were showing signs of anxiety, difficulty sleeping, irritability, restlessness, and the parents themselves were reporting that they were having anxiety and depression as a result of the added responsibility with taking on schooling, remote learning, and having to address things that were normally addressed in the classroom. And then when you think of the classroom, the social development for these children, most of the things that we take into the workforce, they were formed and developed during school. We learned to participate in organized sports, which helps in even in the workforce when we need to work with a team. Outdoor activities such as soccer, Carifta games in the Caribbean, champs in Jamaica, those were all canceled. And so these children were left with the things that were important to them. Outdoor activities, school, were all taken away. And I know in an emergency, in a pandemic, that was necessary. However, now that we can do something about it, now that we have the opportunity to get back to normal, as parents, as adults, we have to take advantage of this opportunity. In terms of like remote learning, I can just think of the outskirts of the island that I'm from, the outskirts of Jamaica. Wi-Fi access is difficult. And if you have 4 kids, most likely you have 1 or 2 computers in the house. So for 4 children to do school work when there's only 2 computers available, that alone is a stressful situation to add on to the fact that they're not having one-on-one interactions with their teachers. So the other area also is nutrition. Some Caribbean islands provide lunch programs for kids who don't always have a balanced diet at home, who are not able to, who are families who aren't able to provide nutritious meals, and they depend on the supply from school that they get. And they are also, families who lose their jobs, they lose wages, that will result in food insecurity. So it's a ripple effect. COVID-19 may not, affect, or there's not a large amount of death for the pediatric population, but they're severely affected. And so as we are today, there isn't a vaccine in the Caribbean that is approved for children. However, we know that it's approved for adults. And it's our responsibility as adults to get our kids back to normalcy, to get our kids back to enjoying life and making the best of their opportunities. And that's basically my plea today is my entire family is vaccinated. At this point, we are planning a trip to Jamaica for the summer. We're planning a trip to St. Kitts for December. And we want to embrace life and allow our kids to thrive the best way they can. And I implore you guys to do the same. Thank you.
And thank you very much, Dr. Julian Wint-Martin. Our next presenter is Dr. Rafael Quanza. He is a specialist in internal medicine, and he is a graduate of the Superior Institute of Medical Sciences of Santiago de Cuba, has been in practice for close to 20 years. He practiced medicine in Jamaica for over 10 years, and Dr. Quanza was born in Ghana. Good evening and welcome.
Thank you, sir. And I'm extremely glad to be here. Thanks for the invitation, Arthur. So I think most of the panelists have actually done what I'm supposed to do, some of them. So most of them has already been done. So thank you all for the wonderful presentations that you put across. You said my name is Rafael, last name is Quanza. Initially, I'm original from Ghana, and then I did medical school in Cuba. And then after that, I relocated to Jamaica. I spent about 10 years working in the hospitals, and then after that, I had a private practice myself somewhere in Lucy. Those that are familiar with Jamaica. So then after that, I relocated to the United States where the residency, I had a resident colleague who is also from St. Kitts as well in the residency program. So after the 3 years of residency, then I came to Alabama, where I have been for the past maybe 6-7 years. And over here, my primary job is hospitalist, so I work mainly in the hospital, do admissions from the ER, see how they come in, admit them, treat, discharge those that can be discharged, pronounce dead those that don't make it, unfortunately, transfer some to higher level of care, and eventually, those that also need other subspecialty consult, we arrange all that. So when the COVID hit, it just became very clear that we were the hospital service was one of the main body or the services that would be right in the middle of the management crew. As we talk now, people still think that probably the COVID is not real. And I think the first thing I want to say is you've heard from most of the panelists, COVID is real. And you cannot overemphasize that much. We just have to understand that this disease is real. And I think some of you that are listening only see the very mild cases. So that will give you some assurance that, most of the disease is just a mild and nothing is really wrong. And that is a very wrong perception. The disease is real. The disease is very devastating. And both the acute phase and the convalescent phase. So let's all take the precautions that we need to and fight this devil. This COVID-19, not the first time we started hearing about it was somewhere in December when it first came out in Wuhan, China. At that time, in the United States, we thought it was kind of too far from us. So, and I think it's the same thing that happens everywhere. And I'm kind of just passionate about the Caribbean because of all the links that I have. And I don't want, in some way, I think it took the United States by some surprise. And I just want us all, both the Caribbean, even back home in Africa, I want us to be on top of this and recognize it right from the beginning that this is real. And preparations have to be put in place to fight this devil. So in December, when this all started, I think Johns Hopkins created a website that they kind of follow the incidents and the mortality and everything that goes on. And before we even came on, they had reported that there is about 171 million cases of COVID-19 in the world. United States alone has about 33 million. And the death in the United States, I think some of the panelists have already said, is 595,808. And probably if you go to the website right now, there are more cases and probably are more deaths. So this is real. It's not like somebody is making things up. These are people that we have seen in the front line dying. And unfortunately, at that time, family members and their loved ones could not even be there with them. So the only people that could be there, hold their hand, pray with them, and let them take their last breath were we, the healthcare providers, which sometimes you finish and you come home and you cannot actually help but just cry whilst you're driving home and when you reach home. So as I said from the beginning, most times people see the very mild cases and they say, okay, then really nothing is wrong. But the CDC came up with some form of classification and the definition of how the disease, the disease itself is. And we know that, severe disease was classified as, people who need hospitalization, admissions to the ICU, people who need intubation or mechanical ventilator support, and eventually those who die. Earlier on, sometimes in May 2020, when we were just initially gathering the data, it became very apparent that about 14% of those that will eventually have the disease will end up in the hospital. And out of that 14%, you could be assured that those that needed to be hospitalized were 6 times more prone to have comorbidities, which most of my panelists have said, and I'll probably go into more details in some of them. 2% were admitted to the ICU, and unfortunately 5% died. And out of the 5% that died, they had 12 times comorbidities associated. And they had about 8 times other organ dysfunctions, which I think Dr. Lee Lewis made mention of. In the early on when the disease came up, I think the CDC from China put up a data about the case fatality. And it became very apparent that 8% fatality rate was in people that were older, and about 70 to 79 years old, and about 15% case fatality people above 80. So one of our main concerns became very apparent that the disease targeted age. And most of the literature has revealed that, age is actually one of the very first or the number one comorbidity that we have. And that is why I usually call upon all of us the moral duty to protect the elderly, because we know that, more than 8% of those who get the disease will, if they are old, 70 to 79, they will die. Now, if they are above 80, that case fatality rate even goes even higher. So it is, yeah, I understand the younger don't get the disease, they don't get the severity of the disease, but then it is our moral obligation and responsibility to protect our grandparents, to protect our parents, to protect the aunt, to protect our church member, to protect our priest. And that's what I think we have to do, because otherwise then we are failing the generation that gave life to us. So that is about age. Now, the other thing that also became apparent in the studies was that people who were in long-term care facilities and nursing homes were more targeted. And I think partly is because they are in an environment that the virus is very easily diffused, and they are also old and they have multiple comorbidities. So it just became very clear that the target was very apparent. The other comorbidities is about sex. In our ICU, we saw a lot of males being primary target of mortality. Some women also died, but we think that more men died. And when you review the literature, male sex is actually a higher risk factor for mortality than the female. It appears, that sex hormones have some protective properties for the women than, for the men. Now, the chronic comorbidities that other panelists have all said about, literature have revealed that, probably about 32% of people who contract the disease and go to hospital have probably cardiovascular disease. And the cardiovascular disease, I think Dr. Lee and Leonard made mention of most of them. Under the cardiovascular disease process, we have the heart failures, we have the coronary artery disease, we have different types of cardiomyopathies. And then we have, the big thing that, predominates in the Caribbean, which is hypertension. And, most of the patients that I have seen typically have either one or two comorbidities. And anytime you add one or two more on top of that, it just kind of raise the mortality even higher. There have been many explanations as to why cardiovascular disease is a major comorbidity, including number one, that there's a vascular endothelial dysfunction itself. There's also a lot of inflammation associated myocardial depression. We've seen a lot of stress related cardiomyopathy in the setting of COVID. And then there is the host response itself that worsen their underlying, like their heart failure or their coronary artery disease itself. So it just becomes a cycle whereby the disease is doing one thing, but then your baseline underlying medical problem itself also becomes completely decompensated because of what the virus is doing. And then diabetes mellitus. 30% of people that come to the hospital that we've seen, those we're talking about the severe cases, typically have diabetes mellitus. And it can be the type 1, it can be the type 2. The one that we typically see in the adult is the type 2. And, if it is a diabetes that is not very controlled, it's worse. But it doesn't really matter. Once you have diabetes mellitus, it's just a major risk factor to have a high mortality than people who don't have diabetes mellitus. And then we have chronic lung diseases. Among the chronic lung disease, we have COPD, we have asthma, we have interstitial lung disease, cystic fibrosis, pulmonary hypertension. And when you add all these, we think about 18% of people who get hospitalized typically have this type of lung disease. And anytime you have one or you have two, your risk of going to the ICU is higher, your risk of mortality gets higher. Cancer. And they've actually typically found out that hematological cancers typically seems to be a little bit worse, poor prognosis than the solid. And among the solid cancer, lung cancer, and then any type of metastatic disease is a major risk factor. CKD has already been said. Obesity is a very big thing here in the United States among the population that I take care of, and also the population I used to take care of in Jamaica. A BMI more than 25 is typically what is considered an overweight. Most people have way more than that. Most people are between 30 to 40, which is really determined as obese. And then when you go above 40, we call that morbid obesity. And the morbid obesity implication is about tenfold. because just the risk of even intubation, if you need that, becomes a problem. There's multiple other things, medication bioavailability and all that becomes compromised. So it's just a whole lot of things that happen when you have this morbid obesity patient that you have to take care of. That's why it becomes a higher risk factor. Sickle cell disease. And I kind of wanted to bring this up because it's a disease that is very common in our race. I think I saw more sickle cell diseases in Jamaica than I've seen in the United States. It's been identified as one of the risk factors. There's actually one common crisis in sickle cell, which is acute chest syndrome. The radiographic changes is almost similar to what we see in the diffuse pattern, like COVID. So if somebody get COVID and they develop that acute chest syndrome with sickle cell, that is going to be very devastating. So that is something to also to keep in mind. Now, immunocompromised states, including primary immunodeficiencies, prolonged steroid use, and the use of immune modulators have all come into play. Transplant recipients, so it can be solid or it can be blood stem transplant. They've all been part of higher risk group. There's been some debate that pregnancy or recently pregnant people are also higher risk, and that becomes very imperative that anybody who is planning to become pregnant gets the vaccine, because your risk of disease complications and disease severity is a lot higher than the non-pregnant population. In what I do, which is seeing the patients in the emergency room, determine where to admit them. If they go to the regular floor, they go to the ICU. There is this severity of symptoms, which we know, as I said, 81% will be fine, but then you have 14% that are going to be admitted. And those patients typically have shortness of breath. They have hypoxemia, which is very low oxygen, or oxygen saturation of 93% or less, or when you have maybe 50% of their lung involvement. Now, critical disease is when you have respiratory failure, or when you have maybe a shock or multi-organ failure. And for those people, mortality is actually extremely high. So I think most of the other panelists mentioned a lot of these risk factors. All that I just kind of wanted to bring to your notice is the disease is real, and the more risk factors you have, the higher the mortality. And either with the Black race or the Caribbean or even the Africa, we tend to have more of these risk factors, and we just have to take the disease more seriously. The disease COVID-19, to me, the area to target or to fight it is not hospital. Once they come to the hospital, the battle is almost lost. We have measures that can prevent the virus from entering into our body, which is social distance, which is face masking, quarantine if you're feeling sick. And then we have measures that we have to use to fight the disease itself. And the best that we have so far is the vaccine. And since we have the vaccine, I can tell you that our ICU is almost back to where it was. We are admitting very little patients with COVID. And every COVID patient that I have admitted now is somebody that has not had a COVID, that has not had the COVID vaccine. So that is the trend that I'm seeing. So please, let's get a vaccine when it is offered. It is safe, it is secure, and the side effect profile is very minimal. I think there are so many people that I attended to who died that if I had offered them the vaccine, they would have jumped on it on the first offer. So thank you so much, and thank you for having me.
And thank you very much.
For the questions.
Thank you so much, Dr. Raphael Kwanzaa, MD, and of course, very poignant presentation. I wish to thank you for that. Coming up next, we have Dr. Cuthbert Sebastian, and Dr. Sebastian is an emergency room physician at the Joseph N. France JNF General Hospital in St. Kitts and Nevis. He's tasked with the responsibility of seeing COVID-19 cases in an emergency setting. He studied at the University of the West Indies Mona campus in Jamaica, and of course he's practicing here in St. Kitts and Nevis. Good evening to you, Dr. Sebastian.
Hello, good evening, everyone. It's an honor to be a part of this panel with such well-decorated colleagues. Thank you for inviting me. So, my goal here tonight is to bring everything home to everyone here. Not just in St. Kitts and Nevis, but in, the general Caribbean region. So I work in the emergency department here in St. Kitts and Nevis, and we have been extremely fortunate here in St. Kitts and Nevis that we haven't had any severe cases of COVID-19. Most of the cases here have recovered well, and cases that have had symptoms, they were mild thus far. So I think we're extremely lucky, and I'm happy for that, because St. Kitts and Nevis, it doesn't have the most robust healthcare system compared to other countries in the world, like the USA, the UK, Canada. Even when some of my co-panelists were mentioning the medications they used to treat COVID-19 patients, in St. Kitts and Nevis, we wouldn't have access to some of those medications in case of a severe illness, a severe case of COVID-19. So that's why it was extremely important in the beginning to prevent COVID-19 from actually reaching the shores of St. Kitts and Nevis, because we would have definitely been overwhelmed, especially during the earlier times of the pandemic. So what I really want to focus on is the healthcare system here is slowly being slightly overwhelmed. And it's not necessarily directly due to COVID-19, but indirectly due to COVID-19. Because what I'm noticing is individuals, they've been out of work for, let's say, for maybe these 14 months. Some individuals are. Some individuals are earning less money because they're only able to work part-time. So I'm noticing patients are slowly coming into the emergency room with minor issues, but issues that could be basically seen at a private physician. Patients aren't able to fill their regular prescriptions, so they would come into the emergency room seeking for help, and some relief for whatever problem or disease or illness or ailment they may have. So when this happens, you're having patients coming into the emergency room. It overwhelms the healthcare team to the point where we're seeing these added patients, but then the individuals who may need our attention immediately, our attention is now divided. The waiting times can be longer because of this. And also, if individuals are rushing into the emergency room, especially during community spread, then there is also a risk of them picking up COVID-19 there in the emergency room, especially with the long waiting times. Now, I have personally seen diagnosed COVID-19 patients here in St. Kitts. in the outpatient and emergency room setting. Thankfully, they weren't severely ill, but they came into the emergency room, and there was a potential that they could be interacting with the public because they wouldn't know that they're positive until they actually get tested. So this is the danger. So like my colleague before me said, we want to prevent individuals from reaching to the hospital in the first place. So that's the goal there. And for instance, the burden of COVID-19 here, if people get sick, they're unable to work. And if people are isolated or quarantined, they're also unable to work. That affects the economy, because if no one's working, then finances and jobs and organizations are going to lose money, and individuals are going to lose money as well. And if individuals lose money, it goes back to my point, they're unable to afford medication, proper drugs, and even food. So I've come across individuals who are actually undernourished in the emergency setting, especially the elderly, where they may not have the ability to go out and get their own food and those type of things. And they need a proper diet and proper hydration, or they can get severely ill. So these are the things that I'm actually seeing. And also the healthcare team, not just myself. So we don't actually we have a limited amount of healthcare workers here in St. Kitts. So we actually just don't work in the emergency department, because I actually do community testing as well outside of the emergency department. So not only am I working in the emergency room for majority of the week, but on my spare time, I'm out doing community testing to basically locate any cases that may have any contacts of a case or anything like that. So the healthcare team is stretched just because of that. And if we are exposing ourselves to more cases here, if the healthcare team gets sick, then who is going to actually take care of the general public here in St. Kitts and Nevis? So then these are other concerns with what's been going on, especially during community spread. So the vaccine kind of gives us an opportunity to actually return to normalcy, especially when we reach the goal of herd immunity. So when we reach the goal of herd immunity, what the vaccine does, it provides us protection against severe illness, hospitalization, and death. So that's what the vaccine can do for us. And if we have enough individuals in the population vaccinated, then we can protect the weaker individuals, or individuals who may not be able to take the vaccine, like the children, for example, like Dr. Martin mentioned. We need to protect the children because they can't take the vaccine, at least the AstraZeneca vaccine that we have here in St. Kitts and Nevis. So we have to, basically do what adults should do and protect our young. So I also wanted to speak about the hesitancy regarding this AstraZeneca vaccine here in St. Kitts and Nevis. Different people have different concerns regarding the vaccine. Many of them can be about blood clots. I know that's a very big concern. Some people are actually worried about future fertility. Some people are worried about even just needles. Some people are simply afraid of needles. Some people take the religious aspect to it. So regarding blood clots, so the AstraZeneca vaccine has had a possible link to blood clots. For instance, in the UK, there's been about 300 cases of blood clots as of last month in total. There's been over 31 million doses given of the AstraZeneca vaccine. So when you do the statistics at the rate at which these individuals are getting blood clots, it's around 13 out of a million there in the UK. Okay, so that's a very, very small number. While COVID-19, like some of my colleagues mentioned previously, it actually leads to blood clots. I looked at the statistic earlier. It says everyone that gets a COVID-19 infection. So 39 out of a million chance that you can get a blood clot from a COVID-19 infection based on the statistics I looked. I'm sure it varies depending on which country or demographic. But as you can see, the rate of blood clots are higher in COVID-19 infection than it is possibly with the chance of you getting a blood clot with the AstraZeneca vaccine. And also the AstraZeneca vaccine prevents the complications that come along with COVID-19. Like my colleagues mentioned prior, there's long COVID, damage to the kidneys. You have MIS-C, multi-system inflammatory syndrome in children. So these are things that the vaccines help to prevent. So it helps to protect your health. And without proper health, there's no way this economy can ever possibly bounce back. It's very hard for the economy to get back to where it used to be, because tourism is a very large factor in St. Kitts and how we make a living here. And it trickles down, so you may not directly work in tourism, but tourism affects nearly every aspect of our economy and our livelihood. So one time I was speaking to an individual, and they work in a tailoring shop, and they said, I don't work in tourism, so why do I have to worry? So I'm like, okay, what about the individuals who are out of work, who work in tourism? How will they afford to get their clothes tailored by you? So you're cutting yourself out from a huge demographic of the population, and that will affect you financially. And if it affects you financially, then that can definitely affect your health, because healthcare is generally, it's an expensive thing. I think it's actually one of the leading causes of bankruptcy in the USA, if I'm not mistaken. And in St. Kitts and Nevis, it's generally cheap compared to other countries in the world. So we're kind of lucky there, but we still don't have that robust access to healthcare that my colleagues in the USA may be able to, have access to. So just to bring home the points, because I think we're a little bit over time, but the vaccine gives us a chance to get back to normalcy. It's been proven safe and effective. All vaccines and all medications have a potential for adverse effects. They all have a potential for adverse effects, and I just want to say the benefit of taking the vaccine definitely outweigh the risk of COVID-19, because like Dr. Martin mentioned earlier, the number of individuals who are in the unvaccinated population, we're looking at hundreds of people possibly dying from COVID-19 or getting severely ill. Those hundreds of people here in St. Kitts is a significant amount of people, because we are a very close-knit community. I can guarantee that at least you would know at least one person here in St. Kitts and Nevis who was affected if COVID-19 actually broke loose here in the country. So my advice is to vaccinate when given the chance, because currently we have a worldwide shortage of vaccines, and in St. Kitts and Nevis, we are lucky enough to have access to this many vaccines. We're not fully there yet, but we're pretty close. Thank you.
Well, thank you very much. I must tell you, time flew this evening. We're almost out of time. We have curfew as well that we have to keep an eye on as well. But we couldn't close the program without getting some more interaction, if you like, from the panelists. You've all had presentations, you've heard each other. But I have a question that came my way from a parent I want to share with you. Just one question. I do apologize to the people who are trying to get through to the program this evening. We're going to probably have to do something in the near future. And one parent did ask me to ask the question, if a child has obstructive sleep apnea, if that child has a high risk for COVID-19. I'm going to just throw it out there for anyone who may want to respond. But I want to give each panelist an opportunity to say a few words to wrap things up this evening. It will have to be very brief because we're almost out of time. But we're debating a very, very important issue. We haven't even started to talk about how do we move forward? What will have to change in terms of, we're talking about responsibility and accountability. How will we have to conduct ourselves going forward? Is COVID here to stay, or is COVID going to be something that is going to be in the rear view mirror shortly? So who would like to go first? The floor is open. Just jump right in.
I'll jump in on that for a moment. COVID-19, I'm sorry, if somebody has obstructive sleep apnea, they are at an increased risk for the complications of COVID, simply because that can lead to pulmonary hypertension and cardiovascular and pulmonary disease. So yes, that and in most cases, the BMI of somebody with sleep apnea, obstructive sleep apnea, is higher than normal, which is again a high risk factor for the worst case scenario for COVID-19. That's not in every single person, because you do have some slim people with obstructive sleep apnea, but for the most part, that does happen. So I just wanted to throw that out. I didn't know if anybody else wanted to say anything. But in closing for me, I just want to mention that the needs of the many outweigh the needs of the few. So that was something that Spock said, but really and truly, it's the utilitarian model of the greatest good for the greatest number. So that's what I think is most important as we go forward. Let's think about our fellow man. Let's think of our children who can't defend themselves because they have no vaccine. We have to protect them. We are the herd that have to protect those that can't protect themselves. And it also is good business for the future.
And the floor remains open for any parting comments, anything you'd like to leave with our listeners, our viewers this evening. What do you really want to say as you leave?
Surely, I think Lorna said it. Obstructive sleep apnea is a high risk for sure. So yes, if it's offered a vaccine, you should take it. I would say that if we all match up very aggressively against the COVID, we can defeat it. If we go about the business in a very casual way, then yes, it's here to stay. I think the only possible way to beat this is if we all get vaccinated and achieve herd immunity, because already we've seen the variants coming in, and that is just it's just one of those steps that is waiting for a disaster to happen. So the earlier we match up, the earlier we get a vaccine, the earlier we reach herd immunity, we will defeat this. If we go about it in a casual way, we are at loss.
So, just to step in and on the behalf of the panelists, and thanks for the teamwork and getting everyone together and really speaking to a topic that is tremendous for the region. This has been a life-changing and historical event in the 21st century. Please do not put your lives and the vaccine on layaway or consignment by waiting to see what happens. We need to really do something to spur a swift economic recovery. and really listen to our professionals, medical professionals and leaders within the region, and in particular St. Kitts, who have done a tremendous job in keeping the population safe and infections down. So, in some recommendations, I'd like to see a non-partisan commission in St. Kitts to tackle COVID now and beyond, and the Caribbean community must also get together and form a functional commission for infectious disease. And I'd like to give thanks to Dr. Thelma Philip Brown, our U.S. ambassador, for actually sponsoring this panel discussion and working closely with not only the St. Kitts diaspora, but other regions as well. I hope the audience have captured the gist of our discussion this evening. And thanks again, Mr. Backus, for moderating this event. And to the people of the Federation and the region that are listening, our prayers are with those who have lost loved ones to COVID-19. And for those who have suffered through this terrible ordeal, may God bless you.
Well, I want to thank you very much, Dr. Martin, for the role you've played. Dr. Winston Arthur Martin, Arthur Winston Martin. I sometimes get your names in different orders, but I think you're...
It's okay, that's the problem. So Kittitians know me as Winston, and sometimes Wham, that's okay, but it's a tough thing when your parents mix up your name and don't register you without a birth certificate. That's what happens in the islands. So.
Well, I want to thank you very much for the role you played, Dr. Thelma Philip Brown as well. Thanks to Dr. Leonard Richardson, thanks to Dr. Colette Lee Lewis, Dr. Julian Wint Martin, Dr. Rafa Kwanzaa, Dr. Cudmore Sebastian. I think you brought us this evening real life accounts that we, I think, are better served now, understanding just how difficult the task is ahead unless we do the right thing. And doing the right thing, of course, is stepping up and taking that vaccine for yourself and for those that you care about. I want to thank you very much, and I hope we can continue our dialogue by one means or the other. And we wish you all the very best indeed, and do have yourselves a pleasant evening.
Thank you.
Thank you. Good night.
Good night to you. And thank you so much for listening to WinFM 90.9. We do appreciate your time, and we do appreciate your company. And thanks to the doctors who found the time to be with us today, just to let you hear from them directly. We have a thing in the Caribbean we talk about from the horse's mouth. Well, this evening you heard from the doctors who are on the front line telling you their story. Thanks as well to Mrs. Yuka Harmony Brown, who played a hand in putting the show together, Trent Sargent, Jade Johnson, and we wish you all the very best indeed. And do have yourself